Here at the Consortium of MS Centers annual meeting, I'm Dr. Daniel Kantor, Neurology in Real Time, and I'm joined here by a great friend of ours, by Dr. Tony Reeder, who is a professor of neurology. He is also the director of MS Infusion Center, clinical trials, committees on neuroimmunology and neurobiology, and almost everything else. Thank you so much for joining us yet again. You have a poster behind us which is about the science of interferons. People back home have heard about interferons because we've been using beta interferons since they were approved since 1993. Tell me about the research that you're presenting here.
First of all, we're comparing Avonex versus Plegridy, which is the latter is a long-acting interferon. Avonex is a short-acting interferon. But why are we doing it? First approved drug, but there's something else going on in the interferon system in MS. It is subnormal. Okay? There's a huge difference between MS patients who have low interferon levels, healthy controls, and people with NMO. It's 10 to 100 times different at these two extremes. And people with NMO get worse on interferons. People with MS get better. And so underlying that, we have an early discovery from our lab. Right here, this is what we found is the underlying fundamental defect in MS in the interferon system. Phosphoserine STAT1, which activates all the genes downstream, is high in relapsing remitting MS. It's normal. Normal controls are here. This is progressive MS. It's low. And then when we take these untreated patient cells and stimulate them with interferon, they respond. Relapsing remitting patients, but not the secondary progressive patients. It sort of correlates with their clinical story. Okay? And so one of our early observations was that MXA, which is an antiviral protein, is low in MS, untreated MS. It's even lower in active disease. Okay? So what we did here, we wanted to see how the system was responding to Plegridy and Avonex. And over here we have this MXA. It's being increased by Avonex, but you'll notice it goes up a little bit at 1 month after a shot. This is 4 hours after a shot for mRNA and 24 hours for protein. But 6 months out, it's really high. So what we've got here is an early interferon effect that gets better over time, and we think the whole system, the low interferons, is being primed to increase, over time. And the same thing happens with Plegridy, all right? But the other thing we've got is a few interesting genes that are different between the two. And Avonex, with its short-term kinetics, goes up at 24 hours. The RNA for ITAC, which is an inhibitory chemokine, it induces Th2 cells to migrate places. Less so with Avonex, but then you look at 48 hours, Avonex is persisting. Plegridy is persisting, Avonex is coming down, and it sort of parallels the need to give it weekly versus every 2 weeks. And the same thing seen with IL-1 receptor antagonist, another inhibitory molecule, up fast with Avonex, slower with Plegridy. But then the interesting thing that's new here, PD-1, which is one of these checkpoint inhibitor molecules that's treated with chemotherapy for cancer, you try to get rid of it to stop the suppression, to make the immune system kill cancer. But in MS, we don't want to do that. We want a quiet immune system. And what we have with PD-1 is both of these drugs are inducing it, and Plegridy has a very powerful long-term effect on PD-1, this inhibitory molecule. So this is a novel finding that Plegridy might be inducing this suppressor molecule that could inhibit MS.
Now, what this means is that interferons, which many people at home have heard about for the treatment of MS, it's important also to understand where interferons are naturally in your body when you have different types of multiple sclerosis. Does that mean that maybe we could have a biomarker where we could test your interferon level and decide whether you should be treated on interferons or whether you should be treated on some of the other medications?
Yes, it does. And that is unpublished work at this point. And the people with the lowest interferon levels, who are the most abnormal, are the ones who do best on interferons. And I was talking about MS versus healthy controls versus NMO with the high interferon, which you don't want to treat with interferons. The same thing's true in this low end. The people with the lowest levels of interferon do best on interferon therapy.
So
That's what's coming down the road.
instead of us just thinking about beta-seron, Rebif, Avenix, Plegridy being a thing of the past, we actually might be targeting and tailoring our treatment more to people who need that interferon treatment, the people with the lower interferons, we want to replace the interferon. That's a simple idea. You're low in something, you want to replace it. So this is great data for us to understand. Now you also talked about checkpoint inhibition. Some people may have seen some of the news articles about how checkpoint inhibitors can actually cause things like multiple sclerosis, can sort of uncover it. Is this related to what we're understanding here? Is this almost the reverse?
Right, it's the reverse. So if you get rid of PD-1, these suppressor molecules, to boost your immune system and fight cancer, what happens? You've got a stronger immune system, and it induces all these really interesting neurologic autoimmune diseases. Okay.
What you're showing here is that although people might debate whether MS is immune-mediated or not, your data once again shows us MS is immune-mediated. And some people use the term autoimmune, other people like the word immune-mediated. Do you have a preference over one or the other?
I think it's immune-mediated, and it's not a simple autoimmune disease because we don't have a target. Like with NMO, we know it's against aquaporin. Okay. Myasthenia gravis, it's against the receptors for a neurotransmitter. MS, no antigen, no virus, no mutation.
So MS is more complicated, but doesn't mean that there isn't hope for us figuring out more. I want to thank you so much, Dr. Tony Reeder, and I want to thank all of you back home. Thank you.